Chapter 9, Joints, Part 1. There are three types of joints in terms of their structure. There are fibrous joints. Fibrous joints are immobile joints where the two bones are connected by dense, irregular connective tissue. There are cartilaginous joints, the name implies, connected by cartilage, this time hyaline cartilage or fibrocartilage. These joints tend to be immovable. They might be able to move a little bit. And then finally, the synovial joints. Synovial joints are very mobile, very movable, and they have a joint cavity, a space that is filled with synovial fluid. Fibrous joints, again, little to no movement, bones connected by dense irregular connective tissue. The most common examples would be sutures of the skull, such as the coronal suture, the lambdoid suture, the two squamous sutures, and the sagittal suture. Cartilaginous joints, little to no movement, although sometimes some movement. Example of these include the symphyses, so pubic symphysis, a piece of fibrocartilage connecting the two hip bones, or the intervertebral discs, another type of symphysis. Synovial joints. Synovial joints are the highly movable joints. When you think of joints, this is probably what you're thinking of. In every synovial joint, they will have a sheet of articular cartilage. This is hyaline cartilage at the smooth ends of the bones where they're coming together to form the joint. There's the articular capsule that connects the bones and the articular cartilage to give us that very important synovial cavity. And then within the synovial cavity is the synovial fluid. Synovial fluid is very thick, viscous fluid that reduces friction, absorbs shocks, tries to make those movements as smooth as possible. And then all synovial joints have to have some external ligaments attaching the bones to each other. So here is a very simple synovial joint. Here's the articular cartilage, up and down. Here's the articular capsule. There's the synovial joint cavity. And then on the outside, we can see the reinforcing ligaments. There are some accessory structures. These structures are in some synovial joints, but not all synovial joints. Again, these are in some synovial joints, but not all synovial joints. So some synovial joints have extra ligaments, either inside the articular capsule or outside of it. Some joints have articular discs of fibrocartilage to help hold and line up the bones and also absorb shock. Sometimes these articular discs are only halvesies, when then they're called a meniscus. So the knee joint has two meniscuses. Another accessory structures are bursa. Bursa are synovial bags filled with synovial fluid. They help to reduce friction, help to keep structures from bumping into each other. And then the tendon sheaths. Tendon sheaths are also fluid-filled structures, but they wrap around tendons, again protecting the tendons as they're going past bones, reducing friction. Movements. There are a variety of movements that occur at our joints. Angular movements are where the angle between bones is changing. So, for example, flexion is a decrease in angle between two bones or more. So here is the knee. If the knee is completely straight out, then it would be at an angle of 180, but as you bend it, as you flex it, that angle decreases. So here in this picture, it's now 90. Extension is the opposite. Extension is increasing the angle between bones. So here again, this leg is at, say, 120. If she continued extending it out till it's completely straight, then it'd be at 180. So again, extension increases the angle between bones. Flexion decreases the angle. And of course, there's also at some joints, but not all, but at some joints, hyperextension. Hyperextension is shown here. Here's flexing at rest, and then hyperextending, going past the 180 line, as it were. So going beyond the extended range. We can do that with our vertebral column as well. We can flex forward to bow, extend back to standing position, and then hyperextend backwards. Another set of movements, abduction and adduction. Abduction is moving the limb so that its distal end is going further and further away from the midline. There's an imaginary piece of string. As you abduct, the string has to get longer and longer. And then adduction is going in the opposite direction, going down, moving the distal end of the limb so it's getting closer to the midline. So again, if you have that string connecting it to the midline, as you adduct, it gets shorter and shorter. Also, you can think of abduction and adduction as being lateral motions, while flexion being anterior and extension being posterior, with the exceptions. Circumduction. Circumduction is moving the end of a limb in such a way as to form a cone in space. It's actually a combination of flexion, extension, hyperextension, abduction, adduction, but it gets its own name, circumduction. Shoulder joint, hip joint, main places that can do that. Rotational movements is turning the bone on an axis so that it's twisting in space. You can have medial rotation and lateral rotation. So if you have your arm at rest like this and laterally rotate, hand's going to turn in such a way that the palm's going to face out. Again, the turning's happening at the hip joint. Medial rotation would go the other way, turning it so that it's going back down, face down. Again, this is movement at the shoulder joints. Special movements, elevation, depression. Elevation, raising something superiorly, depression, lowering it inferiorly. So our mandible, elevate and depress. Our pectoral girdle can elevate and depress. Protraction, retraction, protraction sticking out anteriorly, retraction pulling it back posteriorly. Mandible can protract and retract. Our pectoral girdle can protract and retract. Supination, pronation. Supination, pronation is a movement occurring at that joint between the head of the radius and the radial notch of the ulna. When you pronate, you turn and rotate so that the radius causes the palms to face posteriorly. When you supinate, it rotates the radius in such a way that the palms are facing anteriorly. So supination, you can hold a bowl of soup. Pronation, you can pour it out. Inversion, eversion at the foot. Inversion is turning the foot so the sole of the foot's facing inward or toward the midline. Eversion, turning the foot so that the sole of the foot is facing laterally or away from the midline. Dorsiflexion, plantar flexion. Dorsiflexion, movement at the ankle so that the top of the foot is moving upwards. Plantar flexion is moving at the ankle so that the ball of the foot is going downward. Plantar flexion is what you do when you stand on your tippy toes. Dorsiflexion is what you do when you stand on the heel of your foot. All right, there's some different kinds of synovial joints, and they're defined based on their structure and the movement. So plane joints. Plane joints are where relatively flat surfaces are coming together. See this in the carpals and tarsals. They allow for a little bit of gliding motions back and forth. So flat and a very limited movement. Then we have hinge joints. Hinge joints have a rounded cylinder fitting into a concave trough. So again, cylinder fitting into the trough. They allow for uniaxial movement, specifically flexion and extension. Example, elbows, knees, between the phalanges. Pivot joint. Pivot joint is designed so that one bone and some ligament wraps around another bone, allowing for that other bone that's wrapped around to twist. So that makes it a pivot joint. Examples of a pivot joint where the radius contacts the ulna and where the dens of the axis is in contact with the atlas. And these are uniaxial movements allowing for only rotation to occur. Condylar joints. Condylar joints, again, smooth rounded surface fitting into a more concave surface, cup holding the bowl, as it were. Condylar joints are biaxial, allow for two motions, flexion and extension, and abduction, adduction. So the wrist, for instance, flexion, extension, abduction, adduction. Saddle joints is where one bone is very convex, looks kind of like a saddle. The other bone is very concave, looks like parts of it are going on either sides of the first bone, kind of like the legs of a guy going around a saddle. The saddle structure is biaxial, allowing for abduction, adduction, flexion, extension. The main example is between the carpals and the metacarpal 1 and the carpal right there at the base of the thumb, and that is an important joint for allowing us to grasp things. Ball and socket joint. Ball and socket joint are shoulders and hip joints. They have a big rounded smooth surface fitting into a big ass socket or cup. They allow for lots of movement, so they are multi-axial movement, including flexion, extension, and hyperextension, abduction, adduction, rotation, both medial and lateral rotations. There are different joints that you need to remember the names and parts of. So we have the temporomandibular joint between the condylar process of the mandible articulating with the mandibular fossa of the temporal bone. Within it, there is an articular disc. So the temporomandibular joint has an articular disc inside its articular synovial cavity. And of course, being a synovial joint has to have an articular capsule, synovial fluid, articular cartilage on the smooth surfaces of the bones, and extra ligaments, lots and lots of ligaments. And it allows for elevation and depression, protraction, retraction, and also lateral movement. Move your jaw side to side. A shoulder joint is a ball and socket joint with the head of the humerus fitting into the glenoid cavity of the scapula. It is a synovial joint, so it has an articular capsule, synovial fluid and synovial cavity, articular cartilage lining the surfaces of the bones, lots of ligaments, and also a bursa. Shoulder joint has a bursa. Allows for flexion, extension, hyperextension, circumduction, lateral medial rotation, and abduction, adduction. In the elbow joint, hinge joint has the trochlear knots of the ulna articulating with the trochlea of the humerus, the head of the radius articulating with the capitulum of the humerus. There are articular capsule, articular cartilage, synovial cavity, synovial fluid, ligaments, and a bursa. Our elbow joint has a bursa. It allows for flexion and extension. Hip joint, ball and socket joint. So the big head of the femur fits into the acetabula of the humerus. Again, articular capsule, articular cartilage on the surfaces, synovial cavity with fluid, ligaments. It allows for extension, hyperextension, and flexion, circumduction, medial and lateral rotation, abduction, adduction. Ankle joint. Ankle joint is between the medial malleolus of the tibia and the most distal surface of the tibia with the talus, and the lateral malleolus of the fibula with the talus. It has, of course, articular capsule, fluid cavity, ligaments, lots of ligaments. It allows for dorsiflexion and plantar flexion. Then we have the knee. The knee has the lateral and medial condyles and patellar surface of the femur. Patellar surface of the femur articulates with the patella. Lateral medial condyles of the femur interacts with the lateral and medial condyles of the tibia. And there are ligaments, like the patellar ligament. There's articular capsule with synovial fluid. There are bursae, many bursae in the knee. And there's also two meniscuses, lateral meniscus and medial meniscus, made of fibrocartilage. They are inside the articular cavity. They help to guide the condyles, hold them in place, and reduce friction and absorb shock. There's also a tendon, the quadriceps tendon, going from the quadricep muscles to the patella. And it allows for flexion and extension. Sometimes the knee gets hit laterally, leading to damage of ligaments in the knee, as well as inside the knee cavity. So the ACL, the tibial collateral ligament, the medial meniscus, all can get damaged and have to get surgery to repair them because they heal very slowly. Knee replacement is shaving off the surfaces of the knee and adding metal or plastic components to then make this again a nice smooth surface with eased movement. Disorder, sprains when the ligaments are slightly damaged, dislocation when the bones are out of alignment, they get relocated, re-put back into alignment, popped out, torn cartilage, needing surgery to replace, and arthritis, where there's degeneration of joints, may be caused by inflammation, may be caused just by wearing down. There's osteoarthritis, where the joints just wear down over time. Sorry, it sucks to get old. Rheumatoid arthritis, which is an autoimmune disease that attacks the joints. Gouty arthritis, where uric acid accumulates in the specific joints, usually not all of them, but just like one or two or whatever, but it's very painful. And then Lyme disease, which is a bacterial infection that causes inflammation in many joints, leading to arthritis. That is it for this lecture.